So we are, yes, recording in progress. So officially starting. So the last good afternoon, everyone. Let me see if I can.
Afternoon.
Are you able to see me?
Yes.
So good afternoon and welcome to today's webinar convened by the Ministry of Health in honor of Cancer Survivors Awareness Month. My name is Dr. Angari Kijanjui, and I am delighted to serve as your moderator today. Beyond this role, I'm also the founder of Warrior Glow, a cancer care initiative where we teach cancer patients, what we actually call cancer warriors, how to cope with the side effects of treatment, and also, yes, and create positive cancer awareness. So our work centers around humanizing this cancer journey. And today's conversation is actually close to my heart because it speaks to the next chapter of who we are calling survivors, whereby it's not just surviving, but thriving. And the poster indicated, the theme is from surviving to thriving, empowering survivors through lifestyle and community, which I think is actually a call to action, whereby cancer survivorship, it's not the end of the story. If anything, it's the beginning of a new chapter, and there's need for support and empowerment and all these things. So we have an incredible lineup of speakers. So we have a cancer survivor, we have an advocate, we have a nutritionist who will be able to share with us insights and stories and even strategies. So whether you're a healthcare provider, you're a policymaker, a caregiver, a survivor yourself, your presence here truly, truly matters. So please free to share your reflections and questions in the chat box. We want this to be as interactive and heartfelt as possible. And without any further ado, let's begin. Our first speaker is, just a minute. Yes. Our first speaker is Sydney Misigo Chahonyo, who's the fundraising director, Hope for Cancer Kids. Sydney is a confident professional with experience in the public, private, and social impact sectors. Sydney has been cancer-free for 20 years and is dedicated to changing the cancer landscape. He is passionate about creating lasting social impact regarding holistic childhood cancer care in Kenya. Wow. He serves as the fundraising director of Hope for Cancer Kids Kenya, an organization that is a foundation partner of the St. Jude Global Alliance. He sits on the board of Childhood Cancer International, CCI, and is the vice chair of the African Regional Committee. He also serves on board of the Kenya Network of Cancer Organizations, KENCO. Thank you for your service, Sydney. Finally, Sydney serves in various capacities at the National Cancer Control Program, NCCP, the Childhood Cancer Technical Working Group, TWG, and the Advocacy Partnership Coordination and Financing Technical Working Group. He also serves on two subcommittees, which is advocacy communication, and social mobilization and survivorship. With that, Sydney, the stage is all yours. Karibu sana.
Thank you very much. Can you hear me?
Yes, we can hear you.
Let me just share my screen. Can you see my screen?
Yes, I can see it.
Yes, yes.
All right. Thank you very much for putting this webinar together. I believe that survivorship is a topic that, for the most part, has really been ignored because we are still in low and middle income countries at the point where we are trying to just get early detection and access to treatment. But I do believe that these conversations need to start now if we're going to have a thriving network of survivors. So without further ado, the topic of our webinar today is from surviving to thriving. And by the end of this webinar, we hope that we can be able to empower cancer survivors empower healthcare professionals and anybody in the survivorship network to be able to have a holistic, comprehensive outlook on survivorship and come up with hopefully some programs to be able to support survivors. Um, I use that photo because it's a photo of me smiling. Because at the end of the day, what I'm trying to do is give hope to survivors, to caregivers, to anyone who is connected with the cancer journey. So, trying to understand survivorship. Um, I believe that, first of all, in terms of what is a survivor, in my opinion, is anybody living with cancer from the point of diagnosis. There have been different perspectives on survivorship. Some people say it is once you finish treatment. Some people say it is when you are diagnosed. But for me, I do believe that survivorship does start at diagnosis because from the point of diagnosis, you're fighting to beat this disease. Okay. So we are trying to empower survivors globally. I'll start on the right hand of this slide. In low and middle income countries, survivorship care remains underdeveloped due to limited resources, indicating a need for focused efforts to improve cancer care and support. Annually, we have about 500,000 children surviving cancer each year, which highlights the importance of ongoing support and resources to the growing population of childhood cancer survivors. And as per the WHO and Globocan, as of 2024, there were over 50 million individuals living as cancer survivors globally, marking significant progress in cancer treatment and care. But at the end of the day, where are the survivors? What are they doing? Do we have any sort of way of tracking them or tracing them? Or what kind of support are they getting? And I believe this is one of the questions the webinar will try to answer. I'll first talk a little bit about my journey as a cancer survivor and an advocate. I was diagnosed with cancer at the age of 19, cancer of the postnasal space right after finishing high school. Luckily, I was treated here in Nairobi Hospital and successfully, and I am now over 20 years cancer free. After that experience, I joined Hope for Cancer Kids, which is an organization that supports children from low-income families that cannot access cancer treatment. We ensure access to treatment for affected children by paying Social Health Authority insurance premiums, previously NHIF, from 2008 to be able to give these children access to treatment. Aside from that, we're also involved in supporting out-of-pocket expenses such as transport, accommodation where we can, and other barriers that would stop people from accessing treatment. We are also involved in advocacy and raising awareness about childhood cancer, building research capacity to promote research to enhance treatment options and policy decisions, and also building the capacity of our children and caregivers. So there are very many challenges that survivors face. And one of my goals is to empower cancer survivors, no matter what stage you are in your journey, to be able to navigate the journey of survivorship with support and resilience. One of the challenges faced are physical challenges that impact daily life significantly. Survivors often experience long-term effects like fatigue, chronic pain, organ damage, which affects their overall quality of life. Me, for example, I now have to wear hearing aids because of the long-term exposure to radiotherapy and also due to my chemotherapy drug carboplatin, which both had significant effects on my hearing. One other issue that people face is mental health issues, which are prevalent among survivors. Anxiety, depression, post-traumatic stress disorder, fear of recurrence, and the psychological toll that comes. Myself, I'm now doing checks every year. And every time I go, even though I have been cancer free for 20 years, there's a lot of stress between the point of taking those tests and waiting for the results. It plays a big mental a role in my development because at some point you can't do anything except think about, I hope the cancer is not back, or anytime you get that headache or that nosebleed, those symptoms that remind you of their diagnosis, your mind goes through a process and you have to keep reminding yourself that I'm fine now. Other challenges are social and economic barriers. These include stigma, discrimination. I remember losing my job when my hearing disappeared, and it took a toll on me, both mentally and financially. And basically, these are just some of the challenges. But the reason I chose those pictures, the picture at the top is myself hiking with a group of cancer survivors and caregivers. This was at Ngong Hills about 3 weeks ago with Kilele Health Association. Also with Kilele, we actually climbed Mount Kenya with a bunch of survivors, including a 60-year-old grandmother. We had a young girl who was undergoing chemotherapy at the time. And basically, what we are trying to do is show that cancer should not limit you. Cancer is not the limit, and it cannot define you. Anything is possible. My next slide, give me a minute. I cannot seem to move the slide. There you go. Now, what are some of the organizations in Kenya that are dealing with survivorship? First of all, you have Kilele Health Association, which is an organization of survivors that have come together to support each other. We deal with issues such as mental wellness, physical fitness, also involved in a lot of policy engagement. I'm sure you've seen a lot of information about breast cancer and cervical cancer elimination, and Kilele is really at the forefront of some of those initiatives. Another organization is the Cancer Survivors Association of Kenya, which provides peer support and awareness initiatives to cancer survivors and the general public. As said before, I do serve on the survivorship subcommittee at the National Cancer Control Program. So there are places where survivors can get information and support within Kenya. Um, One of my goals, as I said, is to empower survivors, connecting communities for better survivorship and care. And I want to introduce two different networks. Number one is the Childhood Cancer International Survivor Network, which is called SURNET, which is both of these groups are very new, less than a year old. And the objectives of SURNET is to strengthen survivor groups, especially in low and middle income countries, because you find in Europe, in LATAM, and specific regions like the Americas, they're very strong survivorship networks. But when you come to low and middle income countries like Africa, there's very little structure or coordination. But before that, the one thing we want to do is map where are the childhood cancer survivors. We want to identify and assess the needs of childhood cancer survivors to better understand their experiences and come up with tailored programs to be able to support them in Africa and beyond. One other thing we're trying to do is identify champions for survivorship and find a way of equipping these champions with the resources they need to be able to use their lived experiences to be able to bring about change in the survivorship space. The other network on the right is the SIOP Survivorship Network. For those of you who may not be familiar, SIOP is the International Society for Pediatric Oncology, and they do have a survivorship network which tries to bring together everyone in the medical fraternity and all other SIOP members to be able to see how can survivors be supported more. Both of these organizations have a global focus and a particular emphasis in low and middle income countries where there's less structure. One of the things we are trying to do at SIOP Survivorship Network is policy representation. I sit on the steering group, and one of the things we are trying to do is use our lived experiences and our voices to ensure that critical policy decisions are made to include survivorship. Another thing we are trying to do is collaborate, whereby the SIOP network is mapping all the institutions and organizations that offer some sort of follow-up care or survivorship care, while Childhood Cancer International is trying to find where the actual survivors are, so that once we know where the survivors are and what the needs are, and then we can connect them with the institutions and organizations that provide care, then it'll be more holistic. So just in terms of survivorship, how can we support cancer survivors? Community and lifestyle empowerment is very key, bringing people together through community support, mental health, and lifestyle changes. Community and peer support includes reducing isolation for survivors, because cancer is a very lonely journey. And a lot of the time, not even your spouse or your parents or your family can understand what you're really going through. So you really feel alone. So coming up with some of these networks where survivors don't feel alone, you know that there's someone else who is going through what you went through or something similar, it really reduces that feeling of isolation. Also, what we're trying to do, another way to empower survivors is to give them access to mental health services. Counseling and support groups go a long way in empowering people through their cancer journey. And as I said, some of these mental challenges, cancer is as much mental as it is physical, because your state of mind will really determine your experience of the disease. Another thing we want to do is advocate for policy change. What policies are there in our national cancer control strategy that actually focus on survivorship? What care are survivors given? As I said, in low and middle income countries, we are still looking to get access to treatment and early detection. So survivorship is important, but not yet a priority. But unless we start having those discussions now, it will continue to remain something on the back, something that is not prioritized. Um, Promoting lifestyle empowerment, nutrition, exercise, and wellness programs. Organizations such as Kilele Health, Cancer Survivors Association of Kenya, and worldwide, a lot of organizations are both raising awareness, giving information about how you can treat your body. What do you need to eat to be able to remain healthy? You need to do physical exercise. There are wellness programs and mental health programs out there that can actually support survivors. And then building resilience through support, just encouraging one another through recovery and growth, because at the end of the day, if you don't hold each other's hands, it becomes a very lonely and isolating journey. This is my message to any cancer survivors out there, but I will also just leave it open to everybody else out there who is listening, because at the end of the day, we need our survivors and people who are going through cancer to know these 6 things. One, you are not alone. You are part of a larger community that understands your struggles. The support networks are vital for emotional healing and shared experiences. Secondly, your story matters. Every survivor's journey is unique and valuable. Sharing experiences can inspire others and foster a sense of connecting and understanding. Thirdly, survivorship is thriving. Surviving cancer is just the beginning. True survivorship means embracing life fully and finding joy in everyday moments and achievements. And that is one of the reasons why, with Kilele Health Association, we climb Mount Kenya almost every year, just to let other people know that cancer did not limit me. There are no boundaries. And we are ready to go to the peak of our health and the peak of our life, because at the end of the day, I'm still here, I'm surviving. I'm not just surviving, but I'm also thriving. Number 4, building connections. Creating relationships within the survivor community promotes hope and resilience. These bonds help navigate the challenges that come with survivorship. Collaborative support systems are needed, because at the end of the day, if you have a strong network of friends, family, and healthcare providers working together, then we can be able to provide that encouragement needed to thrive post-cancer. Lastly, which is one of the most important points, especially to survivors, advocacy and awareness is very important. Raising awareness about survivorship can lead to better support policies and resources. Advocacy ensures that survivors' voices are heard and their needs are met through policy and decision making around cancer. So, yes, empowering cancer survivors through community support was the topic of this webinar. And what we're trying to do today is just explore how lifestyle changes and community engagement can uplift cancer survivors and foster resilience in their journeys towards thriving, which is what some of the speakers after me are going to be talking about. And this is just my last slide. Um, and the picture over there is of a lady called Haley. She is a cancer survivor who was treated at St. Jude's Children's Research Hospital. She is now working there as a physician's assistant, and she was the first cancer survivor to go with a prosthetic limb to go into space. So this is just a testament that nothing is impossible for cancer survivors. This is her giving her story and empowering some of the children at Kenyatta National Hospital a couple of weeks ago. So I hope that I have inspired you a little bit to join us in making a meaningful impact on the lives of cancer survivors in your community. By engaging with local cancer support organizations, sharing your personal story, and advocating for enhanced resources and policies, you can help create an environment where survivors feel empowered and supported. Together, we can foster a community that not only acknowledges the struggles of cancer survivors, but actively contributes to their journey towards thriving in life post-cancer. Thank you very much. I am open to any questions. If you have any questions, kindly just put them in the Q&A and we'll be able to address them. I'm not sure if the Q&A session is now or after all the presentations, so I will give it back to you, Dr. Wangari, to guide us in the next phase. Thank you very much.
Oh, wow. Thank you, Sydney, for the presentation. Again, audience, you said we're making it interactive. So I'd like to see claps and, just amazing emojis, appreciating that presentation. And yes, we'll take the questions after all the presentations. So yes, keep them coming on the Q&A. Yeah, so thank you for the insights you shared, for the resources you shared in terms of, other international spaces that are already in the survivorship network. And thank you for reminding that survivorship is not just survivorship. Survivorship it's not just surviving, it's thriving, right? So we'll go on to the next presenter. Our next presenter is Eric Ngereso. He is a notable clinical dietitian based at the Kenyatta National Hospital in Nairobi. He frequently appears in local media and public forums to share expert insights on nutrition and food safety. So probably memwona mahali. Ngereso is a trusted public health communicator in NCD, which is non-communicable disease prevention and care. His multidisciplinary engagement from hospital-based patient care to media highlights his commitment to wider public awareness and advocacy. Eric, the stage is yours. Karibu. Makofi to Eric.
Thank you very much, Dr. Nyanjui, for that wonderful introduction. So I will be presenting on nutrition for cancer survivors. So in this case, I want us to have an understanding of what nutrition does in as much as our health is concerned, both in the context of disease or in the prevention of disease. So I hope you're able to see my screen.
Yes, we can see it.
Thank you. So I'll be looking at nutrition for cancer patients. And in this case, I'll be diving into both the preventive function, at the same time also on the aspect of treatment once one has been diagnosed with the disease. So that as my earlier colleague has mentioned, you find that in their part of their resourcing to the survivors, there is the aspect of nutrition for the purpose of helping in appreciating the role which nutrition has both in prevention and management. You notice that independently nutrition, that is now through our diets, has a role as pertains to the cancer journey. Looking at the diagram projected, you notice that as pertains to causation, chemicals are one of the culprits involved in the initiation of cancer. Now, in this regard, you notice that this could be as pertains to the area of production. That is, are we doing good agricultural practices, for which now much of the focus is tailored around maximizing produce, yet there is the concern around the implications on human health. Besides this, I suppose the slides are moving?
No, sorry. In fact, that was my question. We're still on the first one, nutrition for cancer patients. Yeah.
So maybe you got access to the presentation you share from your end?
Yes, let me attempt. Okay.
Okay, let me stop from here.
Just a minute, just a minute.
All right, all right.
Okay. Has any
A cancer patient, managing a cancer patient, but at the same time also why nutrition is crucial, also as a causality, rather linking to the risk of also, getting the cancer. So looking at the left hand, sorry, you find that there are determinants for which now foods can actually be a contributor to the onset of the cancer. But again, also food itself also has constituents therein that also can help in managing the very cancer as a concern. So for instance, chemicals, as I was mentioning something around good agricultural practices, where now today's society maximizes on maximum output from agricultural activities at the expense of human health. And that's why regulators in the industry also needs to come on board to make this contained. Looking at the other component of excess energy, where now you find people are consuming more than they require. This now ends up now resulting in conditions like overweight and obesity that have been linked onto some forms of cancers. Viruses, aflatoxin, you've had stories around the students, in schools becoming victims to aflatoxin concerns of the contamination, challenges as pertains to matters food safety. Now, of interest here is you find that they've been linked to conditions like, say, cancers of the liver, which if now good handling practices post-harvest management can also help in arresting the challenge. So in this case, you find that food, if yes, already diagnosed, then still prevention also has to be part of the key concerns or entry points to the cancer survivor, or at the same time also manage the existing condition given the challenges they may be presenting with. Now on your right, you can see there is limited antioxidants, other nutrients and non-nutrients, implying that you find that in most say restaurant setups, you find individuals may tend to consume lesser of fruits and vegetables, which are now rich in the antioxidants of interest. Now, majority bulking more on the meats and the carbohydrates, which means the imbalance brings in micronutrient deficiencies that also have been prone to the initiation of cancer. So, looking at the diagram, we can actually do the reverse by now rethinking through in terms of agriculture, food processing, and also consumption at the table level. Next. So like what you're seeing displayed is what I was mentioning on the antioxidants potential that can be obtained from our foods. And that's why in prevention of cancer and also even in treatment, you find that food contains or supplies all the outlined. So these are mainly like phytochemicals that actually serve purposes like, say, being antioxidants, anti-inflammatory support agents, at the same time also immunoboosters holistically, by more or less now helping in arresting free radicals that are also now known to to be a burden or the challenge in matters cancer initiation, but at the same time also reversing one's own treatment. So in this regard, we need to now, like as a patient or as a person knowing or actually now with the interest of preventing cancer, then appreciating the benefits that we will derive from our foods based on what they contain, then serves as a as a stepping stone towards containing challenges that come by with cancer. Next. Now you notice that there are near basic preventable factors, yet despite the communication going across on the subject, still we tend to crawl in adhering or the changing from what has been obvious to us. For example, alcohol has also been linked independently with cancer of the liver, and also, of course, overweight and obesity, a predisposing factor also in other forms of cancers, given that what you're calling the aldehydes therein from alcohol, as substances during metabolism, you find that now they've been linked in the context of initiation or even progression of cancer. So a basic example, like when you say avoidance, then it will be a better statement in the context of radical change to prevent the surges. You remember, like in our previous presentation, there was statistics. But remember, statistics should not be the basis of laying the case bare, but rather a paradigm shift now is required in terms of what are now the preventable tangibles, in terms of this is what you've noticed to be the trigger factor or the link factor. But then now, this is now what you are doing as pertains to, now through advocacy, as earlier mentioned, that we are taking steps in containing the surge in the consumption of alcohol, including the illegal liquors. But you notice even in a country as alcohol is a crisis as of now, including now the recent concerns among our university students in entirety. Coffee and tea. Of course, in this case, you find that one would wonder coffee in the cold season has relevance, but you find that number one, of course, it dehydrates an individual, meaning, and remember, water is crucial in helping in one, driving away free radicals in our bodies that also now may tend to be cytotoxic if levels accumulate beyond the tolerable limits. Besides now the sugar attached to it, because remember, for a cup of coffee to taste, one has to put in an adequate threshold of sugar, and therefore you also won't take it plainly. Instead, you have an accompaniment. So depending on how sweet or how hot it is, you end up now consuming more calories, energy, accounting for the challenges that you are discussing. So whether in prevention or during treatment, these are elements that need to be fixed. Artificial sweeteners, you find that people may tend to want to be, conscious about their health. So they substitute, say, sugar with either, say, honey, and therefore also even artificial sweeteners, which themselves also have been culprits as pertains to, in the onset or initiation of some forms of cancers as we speak today. We have chemicals in the context of nitrates, nitrites, and strosamines. Basically, these are used in preserving meat and meat products. Now, in particular, for example, at the market level, you find the element, what keeps sausages brightly colored as they appear. And remember back, some years ago, there was the concern around some supermarkets preserving, or rather, preserving the meat's use, retaining the integrity of the meat as though it has been slaughtered today, or even some butcheries. Basically, those chemical agents of interest that are known or have been linked with being a pro-cancer initiation. Then method of food preparation. You notice that majority of individuals, you think of food for your, say like some of you have just had lunch, the githeri is fried, meaning again also if there was some vegetable attached, then also even the skuma was also fried. If you do meat, chicken, some chicken, ugali, rather not even ugali, but now you put it rice, chicken, and then some cabbage, all the three shall be fried. So meaning upon now consumption, of course, it will be rich in energy. But number two, besides that, once you start metabolizing the fat, now the radicals in the context of, like say, for this case, aldehydes will also be pro the carcinogenesis you're talking about. So even in the interest of also wanting to lose weight, then of course, cutting down on the cooking method in terms of now minimal frying can be a way to go. Now, take a look at, for instance, the fries that we consume in our centers, even some deep fried fishes in the markets. The question is, for how long has the very fish you just bought in the oil they were using in frying, for how long has that oil been used? Remember, superheating of cooking oil, even if it was olive or whatever brand you want to call it, vegetable, healthy, no. High temperatures destroy the benefits attached to that particular oil. So in the context of economics, you find that now somebody will always end up now reusing the oil, be it in the restaurants or even in our homes, in the interest of containing the cost of living. But the more you overheat it, and therefore the high risk of also production of the aldehydes essential in the risk of cancer onset. Proceed. So you notice that the key concern as of now is, given the statistics, we need to fight the numbers by also looking at how are the outcomes. Outcomes should now be our new frontier as a concern. If you can zoom through now in the diagram, you notice that you're looking at the global mortality attributable to dietary composition and weight, that in nearly, like say, looking at the third bar from your left, just by consuming low fruits, it's independently linked to some forms of cancer. On your right, there is that scale that shows you the color code and the disease involved. And then there is also whole grains. Remember, much of the industry today is processed. So processed also means inflammation risk, and therefore, again, also overweight and obesity issues, and therefore linking to some forms of cancers, low intake of vegetables. Of course, then there is near justification among many that they don't trust the various available options in the market because they don't know where they've been grown. But you see now, there is also opportunity as a person in terms of engaging in agri-nutrition, where now you do small kitchen gardens within your spaces to also participate in in-house food security. So you notice that across board, that there is now the express link that has been outlined as pertaining to dietary composition. So you miss out on some nutrients. Remember, like I mentioned about free radicals from the initial diagram I indicated, then of course you predispose to risk. But again, also excess weight, as you'll see in the subsequent slides, has also been implicated in this. So that's why, yes, already diagnosed, then if already having excess weight, of course, it means also you also need to shed the pounds. But if you want to also prevent, then lose earlier so that now you don't struggle during treatment. Next. Now, this is a snapshot of the progress towards global nutrition targets. And I want us to pay attention on the last row, where now you're looking at obesity in men. And on the second row, there is the last on your right, there is the obesity in women. Virtually, ideally, nearly all countries, the 190, they are off target. So meaning, given the statistics that my colleague shared earlier, the numbers, yes, they'll progressively keep on rising. Go ahead. Now, what's happening elsewhere? You find that there are some countries where now people have taken initiatives to also do public awareness in terms of what is available in the market, what is this that can consider clean, and what is this that can consider dirty, where now they rank to guide shoppers or the consumers in terms of you what to buy, what do you buy, and why, what is the basis in terms of, like, say, looking at the pesticides therein. So, but now looking at the, maybe in our own setting, local or wherever where you are just coming from, the audience, you find that it's open market. So you only, it's actually choices at your own peril. But then now, as an advocacy entity, then it's a high time we need to pursue directions of this kind as part of public awareness. Next. So why does nutrition matter? As I said earlier, you find that, yes, we've been concerned with the numbers, and therefore the uptake also has been there in terms of treatment. But then the question is outcomes. So nutrition supports treatment outcomes. Number two, manages side effects as we move down the slides, and then helps in maintaining the weight and strength. Because remember, once somebody loses weight, even psychologically, they also become depressed about the situation. And then number two, if you're not able to have enough strength within you because now you're not powered through eating, then obviously even the quality of life becomes compromised. And you see, these are the determinants or definers of treatment outcomes. Next. So this is more or less like an overview of what has already been discussed. You find that globally, in terms of outcomes, 1 in 6 will end up dying. But as of 2030, the projection is the cases are going to increase by about 50%. Now, this increase now, as I said earlier, will be justified or will remain true if the habits outlined earlier in terms of now the link between nutrition, the food system, and therefore the cancer diagnosis remains status quo. A good example also I've shared is on the trends, global trends as pertains to, like, say, managing overweight and obesity, so that if there is nothing that has been done to this hour, then of course, as of 2012, we were at about 14 million. So we are 12 years, about 13 years into the journey towards 2030. So it means in this 50%, it means now you're actually somewhere close to 25% increase already as we speak now. So unless status quo is actually addressed, then 21 million will be true come 2021. Now, of concern is that the death has been projected to increase by 60%. Death has been projected to increase by 60% during the same period. So meaning, if advocacy, as my colleague has mentioned, if not handled now in areas of policy and public goodwill, then you'll find that yes, we'll continue now losing unless we turn the tide. Next. Now, back home, you find that in terms of mortality from cancer, among women, 57%, meaning you diagnose 5, no, not 5, rather 10, half of them will die. Our neighbors in Tanzania, they are at 58-42, Uganda 54-46, more or less same trend, which means as we also forge towards East African community, then the question is, it means actually we have common problems, which means solutions also can actually arise from within us by turning the tide against matters investment towards prevention and also treating the already existing in a different way. Proceed. So this more or less a continuation of the statistics as earlier mentioned. You find that every year we detect 39,000 cases and 27,000 will almost now, die. So meaning, it's like what the statistics have just shown, that half of them will end up, over half, in fact, this is more than half of the number diagnosed. So meaning, with the time, unless now we address the issue of treatment outcomes through nutrition, then the statistics will keep on staggering. Proceed. Now, there is a study that was done by Nyangasi and the team in the year 2023. And what I picked out of this was their recommendations as pertains to informing policy that guides future expansion and service improvement. So this is actually aimed at helping in optimizing cancer service delivery at regional centers with the aim of improving patient outcomes. So it's no longer now the numbers in terms of how many are we diagnosing. Now the shift should be towards outcomes. Because you find that if you look at even what counties have done as of now, I would say virtually there is nearly a cancer treatment center in nearly every county. But see now, what happens with that within that cancer center is now should be the new focus in terms of improving outcomes. And outcomes, of course, in this case, as I said earlier on, is focusing on quality of life post-diagnosis all through post-treatment and moving forward. So yes, there is increased patient visits that shows good service uptake, implying that when it comes to access, we've done well, but outcomes, it should be now the next frontier. Next. Well, these challenges and opportunities were actually picked from that study, where now the first one was limited access to care. And as I've now said, yes, there is some progress in that line. Late diagnosis is another one. 7 in 10 come late. And this therefore means it's also true that higher mortality and increased healthcare costs or the spending will be real. But then now you find that beyond access, therefore it means now the other focus would be matters around public awareness, early screening for early detection, and therefore eventually through campaigns as an opportunity can help now in improving. You get the cases much earlier, intervene earlier before advanced disease, and this actually has an overall benefit of reducing the burden of cancer in the country, because the outcomes, one, will also be enhanced, but number two, the burden will have come down because people are aware of how to change or how to modify their lifestyles in the essence of prevention, and therefore minimal burden for the country holistically. Proceed. This is what nutrition does to our bodies, meaning in prevention, nourishment remains a function. But again, also even during the disease state, you still need to be fed so that one, there is enough energy, you retain lean body mass, you maintain acid-base balance, fluid balance, or other electrolyte balance. And of course, other regulatory functions remain near homeostatic. But you find that in the context of late diagnosis, and then now treatment is initiated minus timely and focused nutrition interventions, that independently becomes one risk factor in compromising outcomes. So what you're mentioning here is ideally, yes, nutrition has to be forefront, one, to feed this patient so that now he has the energy to also withstand the treatment. Remember also, depression, psychological concerns will come in if, of course, you've got no energy to maintain your own routine life. That has been the case. For example, you find that if, like Mr. Chahonyo mentioned, that you lose your job, and of course, then the other thing you find that also you're also weak, you can't even do anything, you're not moving. That independently can actually predict poor outcomes, because now you are tired, so you're becoming dependent. So we are emphasizing on the need for nutrition so that one, you maintain normal physiological functions and processes. Proceed. As pertains to matters prevention and treatment, there is the beneficial components you mentioned earlier in the name of phytochemicals that have pharmacological roles or functions, including detoxification, immune function boosting, inflammatory response, antioxidant activity, and also inducing enzyme activity. So you find that with these benefits outlined, then good nutrition, which now of course can only be best arrived at now through conversation with a professional in the subject, but again also not mainly in the disease state, but rather in your in daily living, so that now you prevent any further new cases of cancer from coming on board, or holistically being cancer-free lifelong. Proceed. So what happens when now there is a client or a patient with cancer disease? So you find that they'll undergo medical management, but at the same time they also need to undergo nutritional management, at the same time. You notice that programs like maternal, infant, and young child nutrition are nearly well established, where now it's near like there is an established system for every step to account for a professional coming in to see the patient or the baby or the child sail through the journey holistically. But some programs now, including now the NCD here in the name of cancer, there are gaps existing, where now at times a patient now may have a referral to a nutritionist in the late stage. But remember, our aim here in the context of nutrition is to prevent or correct nutritional deficiencies. So if detected early, then it means also you're able to reverse further onset or even now improve on matters health outcomes. But also of importance is minimizing weight loss, because once lethargy sets in and therefore people lose weight, they become eventually bedridden. This therefore means there is also in-house pressure in terms of looking for a caregiver to take charge to this now adult or even child who is not able to be self-dependent. So what do we do in nutrition? Number one, we may advise on oral feeding, which means now depending on the staging, if somebody does not require really intensive care, you find in management, you find that they'll just be counseled or guided or educated on how to eat healthy as pertains to one, their disease state. But as the severity progresses, which is tied onto the staging of referral, we find that there is now the other option of doing enteral tube feeding. Now it means either you can feed using tubes so that now you deliver nutrients to this patient, but then also some may tend to resist in the name of, you see, relatives may assume this is more or less near death. But remember, this based on the staging of a patient, you find that the more severe the disease has come, and therefore it also requires modified feeding to be able to meet energy requirements. But then now parenteral feeding comes in later, if at all you cannot feed orally or using the tube. So remember, as we go down the options in terms of nutrition interventions, now also the cost rises higher. So that's why the emphasis in this discussion now is that early referral for timely intervention, so that now we don't go progressing much further onto near expensive interventions, because you see now you can't actually see the patient starve in the name of advanced disease. So as part of palliative interventions, still you are fed parenterally so that now you more or less can get the energy to withstand the treatment thereof. But you see, when progress is promising, then also we also reverse the tide in terms of from parenteral, we still transition back onto enteral feeding, and then eventually even discharge home on or normal feeding. So collaboration as a team is very crucial. Proceed. So you notice that in the medical treatment arm, depending on the nature or diversity of interventions that have been instituted on the patient, there are established real-time challenges in the name of side effects that may tend to compromise intake. So such like including weight loss will be real, because now the side effects, including like say fatigue, nausea, vomiting, diarrhea, or even constipation, may tend now to affect overall eating of the patient. So this is now where the genesis begins in terms of you had a normal weight at diagnosis, but then now the dynamics in terms of treatment, and of which now there is no timely intervention to help you respond or address to each of the challenges, you find that now you end up falling into the late stages, as I've explained earlier, in terms of now that may require more specialized feeding techniques that come actually at a cost in themselves. So we recognize that side effects will be there during treatment, and therefore timely interventions, as you see down the slides, becomes crucial. You see? So with those side effects, you notice that now we're likely to fall into malnutrition, which by itself also, number one, we'll see the rise in morbidity, as in other co-infections coming because of lowered immunity. Now with this, it means there'll be recurrent rehospitalizations, and those already admitted, it means now they also tend to stay longer. Now staying longer in the hospital also means psychological stress, because now they've left what has been normal to them in their normal routine life environment, but then now they are in the ward. So meaning prolonged stay, given now the reduced immunity. Mortality, yes, as an outcome, as I've said, is what now should be the new focus. And then higher costs, because prolonged stay also means comes with its own cost as pertains to the nature of treatment being administered to the patient, but again also even the length of stay. Proceed. So this is just an outline of an example of a form of a side effect that a patient may have. And you see with this, he or she cannot actually be in a position to eat orally as has been normal. And therefore, nutritionally, either you may change on the nature of the diet you're giving. So like you give a blunt diet that now may help in responding to the source presenting, or you bypass by using an esophageal tube where you deliver nutrients directly to the stomach, or you can actually do what? Have a parental support in terms of nutrition, so that now you still feed this patient. Otherwise, a week or a day post presenting with such a challenge, it means now they end up catabolizing, explaining the progressive weight loss. Next. So before intervention, both in prevention, also even the disease, one has to undergo what you're calling the nutrition care process, where now you assess to determine your requirement or your status. So that now it informs the diagnosis, and therefore intervention is done, and then follow-up is initiated, so that now to assess on the dynamics that are being looked into. So like, for instance, you came with a complaint around constipation, or rather vomiting, nausea. Now there is a challenge around now the BMI having reduced, rather gone down, given that you've lost weight. You are put on a program or other intervention. Then you also want to be reviewed routinely to respond timely to the challenges that may be presenting. Because remember, even during treatment, you may have diarrhea today, but then next time you also have constipation. All those have nutrition intervention strategies to help in seeing the patient still continue to feed. Proceed. So you notice that in terms of energy and macronutrient requirements, for a healthy individual, yet yes, without cancer, for example, that is the allowance per kg per day. But then you notice that given the challenges in the context of cancer, you find that there is a relative increased allowance, so that now you can be able to cover up for those deficits that may set in, given the side effects that they may be undergoing during treatment. Next. So in these regimens, both in preventing and also in managing, there are essential nutrients for cancer patients, include number one, protein. So there is the myth in the market that, for instance, say no meat, or maybe even plant protein, because of the perceived issue linkage to like the chemicals used in production. But remember, proteins are essential for matters muscle mass and strength, and also, of course, tear and wear management as pertains to these patients. Of course, immunity as well, because the immune fighting cells are protein in nature. Calories, of course, they need to feed adequately as per the table I mentioned earlier. So that now, if they don't feed, therefore the body starts to break down their own tissues. That is what explains the wasting that is normally experienced progressively over time. So vitamins and minerals for matters supporting immune function, but these ones will come from fruits and vegetables. Like, remember the diagram I showed you, a diet that is deficient in any of those, it means the immune function of this individual will be much lower. Hydration, so that for the purpose of one, detoxification, but then again also maintaining normal physiological functions, because you actually can be tired, one, because if you're dehydrated, then there is not enough blood volume to circulate on oxygen and glucose to the tissues. So that can actually see the lethargy set in among this group of individuals. Proceed. So the table outlines some of the strategies or interventions as pertains to the nutrition interventions in managing the earlier reported side effects of treatment. So, for example, if there is taste alteration, which is now reported by the patient, you find now you may need to do, like say, emphasis on experimenting with what works best to the patient. So then once you work with them, they'll actually get to learn that there's a way out, other than now they've been served the usual meals in their houses. Because now the family appreciate that now they are not tolerating the food anymore, you bring in suggestions that can actually help in averting the challenge. Early satiety, for example. See, if there is bloating and gas, a patient may assume as though they are full, yet they've not eaten. So with that, you find that by explaining to the patient that that is only merely bloating, so once they pass flutters, they need to feed in enough to bulk their stomach, so that now they can make call. So, but you see, if they look at the bloating and see it as a hindrance, then you find that, of course, constipation also will become near obvious. That in itself also worsens the outcomes in consideration. Next. So this is a continuation. Proceed. So, but there are events now where you can use some drugs to help in managing those who are struggling with weight loss in cancer. So there are appetite stimulants. These are prescribed just to help in boosting on the appetite, mainly the vitamins. We also have metabolic agents. So also as part of the prescriptions, prokinetic drugs, like for those who are having issues, constipation or other, failed gut motility, and also even anabolic agents. So mainly these are drugs that actually help in upping the appetite just to foster regular feeding. And of course, a basic element like, say, encouraging the patient to serve smaller portions frequently, like say in the tune of 2 to 3 hours, that in itself also can see as avert the side effects being discussed. Next. So what are the recommendations? One, that variety is of emphasis so that now you're able to get the benefit of varying nutrients from the different food sources. So if it's in the category, like say, of carbohydrate, not carbohydrate, but other cereals and starches, then other than just relying on ugali alone, then we can change to say matoke, there is rice, there is chapati. So diversifying on the alternatives to get the benefits of each of the varying nutrient portfolios in each of these foods. But then number two, it also will help you in avoiding boredom. Because remember, if say you are sick, or even if you're not sick, and then now you're serving the same meal nearly routinely every day, then of course, independently, you're likely to end up sinking into food aversions. And you see, in so doing, of course, it becomes a risk in terms of you end up starving. And then now, if already you're in the disease, yet now there are side effects also presenting, then by varying the various food alternatives, then boredom to the patient is minimized. Then adopt a physically active lifestyle. Of course, even by taking a walk, maintaining near normal routine stimulates, number one, appetite. Number two, psychologically you become relieved of the diagnosis, as in, if people see you walk around, then they are like, I think he or she is progressing very well. Then number two, of course, it also enhances muscle strength, including also bone strength. So this is encouraged across board, whether in the prevention facet or during treatment. So, and then achieving and maintaining a healthy body weight throughout life. So a basic element like, say, checking your body mass index to get to know how healthy your weight is in relation to your height is a very small entity, but very crucial. So just walk into any facility next door, get to know where you are. Is it healthy for given your height? So that now with the time you're putting things into check. Number four, limiting consumption of alcohol. But the last word I would say to that on that is I would rather you avoid. Because even if now somebody is sick, neither do we give them any form of alcohol, even if they can afford through SHA. So the plate highlight, just indicated is just now is a sample outline of how you need to arrange your plate in terms of when you're feeding. Next. So the focus here should be on whole foods, not unprocessed. So here you talk about whole, you're talking about, say, if it's ugali, you do grade 2 other than the unprocessed packaged alternatives, or of, the likes of duma, sweet potato, arrowroots, yam, matoke, come in as friendly alternatives in terms of wholeness. So that now you get the benefits of one, the micronutrients therein, but also number two, fiber. Fiber, which has been linked in helping relieve matters constipation, that has a direct link in matters colonic inflammation. If the bowels stay longer, then of course gut issues may end up setting in. So whole is preferred. And then a variety of fruits and vegetables, just to get the benefit of the phytochemicals that we discussed earlier. Lean protein sources, so like in the context of meats, other than going for the offals, you'd rather now buy, say, for example, steak. One would say it's expensive, but now you're not going to clear the entire quarter per sitting, but rather you'll actually have the portion spread across the day. So whole grains and healthy fats remain the emphasis in the discussion. So as I said, healthy fats, remember I said you could be even using a vegetable oil, but overheating makes it unhealthy. Next. So I would conclude by saying that nutrition is essential in matters prevention and treatment, but then early case referral and working as a team is key to optimizing clinical outcomes. Thank you.
Oh, wow. Thank you, Eric. Again, Makofi, audience. That was such an insightful, really insightful conversation. And it reminded me the famous quote, let medicine be thy food and food be thy medicine.
Right,
Truly,
right.
yeah. Yeah. And just back to the simple thing like hydration. I mean, we know water is good, but I think also understanding just how it comes to play in terms of someone who's going through treatment and just prevention was really amazing to know. So thank you for that. Yeah, there's also the food safety component, Eric, yeah, in terms of what we are using to grow our food, how we are conserving our food. Like
Right.
nutrition is really, there's a lot in there, and I'm happy that we're having this conversation, and I hope we keep having more. You know, that
Sure.
to the extent where we're able to actually pick out in terms of local food, you know, what are the components, what are the nutritional ingredients there in that maybe someone who's going through a particular ailment or someone who's in treatment should focus on, yeah? Like where we can break it down to mere pumpkin leaves or, you know, yeah.
Yeah, you're right, sure.
Yeah, I think the reason as to why I'm very almost passionate about this is, as I mentioned, I founded a cancer care initiative, and during our sessions, we also have a nutrition session, and it's the most popular session just because patients have a lot of questions in regards to food. There's a
You're
lot
right.
in terms of myths and misconceptions of what you're supposed to eat or not to eat once you get the diagnosis. And sometimes a lot of information that is on the internet is not correct. And when it is correct, it's not customized for the local context in terms of affordability and availability. So it's
You're
really
right.
good to hear, you know, these conversations and looking forward to us truly breaking it down, you know, to why you should take njugu because njugu has this, you know, ground nuts and it will help in this. Okay, so we have one more speaker. I hope we're still excited to learn, but she's currently having some issues. So I think we can take this time to bring in our questions for the first two speakers, which is Sydney and Eric.
I can speak English.
Who's this? Lucy? Oh, lovely. Okay, so good to know. So just a minute. Allow me to read your bio, Lucy. So, So Lucy Njeri is a health systems advocate with lived experience as a breast cancer. Experience as a breast cancer survivor. She advocates for accessible, affordable, and timely treatment for quality survivorship. She sits in various technical working groups in the National Cancer Control Program, NCCP. She's a facilitator with A Fresh Chapter and Mizizi workshops for emotional healing. She's also the chair of the Scars to Star support group, doing cancer awareness, patient navigation, and rehabilitation. She is also a member of KENCO and a member of Inspire to Live. Wow, thank you for your service, Lucy. You're truly an amazing advocate. And in regards to, you know, what Sydney was advocating, where we get to provide a space for survivors to be advocates, you're truly a living experience. Karibu sana. We're ready to hear from you. Lucy?
Thank you so much, Wangari. I could be having issues with technology. I'll be able to present. I was unable to share the slides with you, but it is okay. I can share later. So what is cancer survivorship? A person who has had cancer is commonly known as a cancer survivor, and survivorship will start at the point of diagnosis. It was 1 month ago, or 2 weeks ago, 10 years or 15 years, we are all cancer survivors. Acute survivorship starts at diagnosis. Initial treatment is focused. extended survivorship.
Sorry,
Starts.
Lucy.
Yes.
Sorry, is there a way we can have your voice or audio louder?
Okay, I'm not loud enough. Sorry.
A bit on the softer side.
Can you hear me
Okay.
better?
Yes.
That is much better. Okay, thank you. So I had asked what is cancer survivorship, and I said it's somebody who has gone through cancer, and we have two acute and extended. Anybody who has a diagnosis, from the point of diagnosis is when you're referred as a cancer survivor. And I've talked about acute survivorship that starts at diagnosis through to the end of the treatment. And we also have the extended survivorships that starts at the end initial of the treatment, months afterwards. And we have permanent survivorship where people have passed years since they finished their cancer treatment and have a less chance of cancer coming back. So a survivor, anybody who has a cancer diagnosis, survivorship starts at diagnosis. The key aspects that we look at are the physical recovery, the emotional and health and mental health, which we don't pay a lot of attention to. Most of the time, the physical recovery is the one that is being focused on. And then you have the social and community integration. And what follows last is the surveillance, the follow-up. So on the physical recovery, we have the treatment plan, we have the multidisciplinary committees sitting and saying, hey, this person has cancer X, this is what we're going to look at, this is the treatment plan, this is the follow-up, 1, 2, 3, 4, 5. Then we have mental and emotional health, something that we've discovered it has not been there. I often say that they treat the disease, but they don't treat the person. Because if you're treating a person, you should be aware of their emotional turmoils that they are going through. So it's very important to start looking at emotional healing before you administer the chemo to that patient, before you give them the injection. How are you feeling? How do you feel about the treatment we are giving you? How are you faring on? And probably that person will tell you that I'm overwhelmed with emotions. I want to cry. I feel I have burnout, and it is good to pay attention. It is part of the healing, apart from the physical recovery. Then we have the social and community integration. Yes, after we've got cancer and we've gone through treatment, we need to be integrated back to the society and to the community. And still there's a lot of stigma that is going on the community. And probably as cancer survivors coming out and speaking, giving our stories and showing people that there is life beyond, or you can be having cancer, you still belong to the community and the society. And the surveillance part, it goes for the doctor, the medication in case anything happens. You know, once one has got cancer, there are many opportunity diseases that are coming up. And nowadays we are looking at non-communicable. We have people who had cancer, got treatment, and they're fighting diabetes, they're fighting hypertension. So it is good for us to go for the surveillance. What are the challenges that the cancer survivors or survivorship has? The health system challenges. We have very poor index suspicion among health workers. Yes, I went into the hospital and they said I had mastitis. I went to another institution, they said I had fibroadenoma, until I went to the third institution and they found that it was cancer. So poor index suspicion among health workers is something that should be looked at. Then we lack health education among patients. Yeah. And that is something that we have taken up as survivors or people living with cancers and the health practitioners to have us go and educate our people in the community about changes in their body and what to expect and when to run to the hospital. And then we have lack adequate trained personnel. Yes, it's happening. I know people are overwhelmed, but they're trying their best. And we hope that in future we're going to have a fellowship for most of the doctors, nurses, all those people in the medical practitioners to go and increase their knowledge and of course to up their game. We have poor patient navigation in the community. We have taken it as survivors to navigate the people that have been diagnosed or have a cancer diagnosis up to link it to the health system. So that is one of the things that we survivors are doing, and acknowledging the gaps as we handle as survivors. I also want to mention that another challenge
are facing survivorship is inadequate insurance cover. I don't want to talk about SHA, but we know that things are rolling, some are not rolling, some are working. They say this diagnosis is covered. We've not seen any person that has been covered with the diagnosis. We have seen that so that the cancer can be caught early. Then we have patients factors, low awareness, and then accessibility to treatment, and rehabilitation and loss of employment and livelihood. You are all going to agree with me that access to treatment is a challenge. People have tried, the Ministry of Health have tried, many people have tried, but still access to treatment is still a challenge for many of the patients, and the high cost of treating cancer. And after the treatment, if one happens to have lost a part of the body, lost your breast, your arm, your leg, you have to use colostomy bag. Rehabilitation is still a challenge, and we're still lobbying that it should be looked at, and loss of livelihood and employment. You become a liability to your employer. Once you have cancer, they see you as non-productive, or you depend so much on them, and you're going to lend them the services that you're giving. You need a lot of time for going to the hospital, offs, leaves, which is a challenge to the patient. Then we have societal factors. We have myths and misconception and economical struggle and awareness level. And then we have stigma, both self and external. Yeah, for those people who have got cancer, there's that initiative of, oh yeah, mimi niligonjeka, I can't do this, please help me. That is self. You see you less, you see yourself less of a person. And then we have the external stigma, wale, those people who have cancer, we are regarded as them. It's as if we prayed for the disease to come, but anyway, it found us. Then we have the physical challenges, those of us who have lost their body parts, and also your self-esteem. Sometimes movement for people or walking is a challenge. Okay, going to the washroom is also a challenge. Then you have the emotional challenge, where people have anxiety, depression, and fear of reoccurrence is real. Anxiety, yes, it happens to everybody else, but once you have a cancer diagnosis, it's not the same, emotionally the same. What are the solutions that I think is Lucy? We could look at capacity building for health workers and ongoing trainings for mentorship, oncology training programs instituted in the country, advocate for health insurance to offer full coverage for oncology, sensitization to the public about early detection, and the need to adhere to treatment. Yes, we are known of starting doing treatment, then it is to a point, and we stop treatment for various reasons that are not valid. And for me, that one, I refer it as chimpanzee suffering, where we have survivors or people in the community mimicking the healthcare providers. And we have people doing this to alleviate anxiety and pain to the people. So you find that somebody is going to tell you, they've said this and this cures cancer, so stop doing this treatment and probably look at this treatment, whereby we find that we lose a lot of people, and the cancer happens to elevate or go to the next step. And then we have the need for the uptake of SHA. We still have a lot of siasas per ground. It's working, it's not working, it's for who and who we have to pay upfront. And right now there's a lot of mishaps that's happening, but we still need to tell our people and educate them the importance of having that SHA, whether it has challenges or not, because in one way or another, it elevates it helps in matters of financing. Then advocacies to employee support and on patients support groups. Yeah, we need to look at the support groups that we're having within our species. We pray that these people get employed, get good jobs, because they are doing a very good job to the grassroots, creating awareness, navigating people, and even giving a helping hand where they are able. And also we have to do a lot of public education. Yeah, we have to do. Community integration and the importance, it reduces the feeling of isolations and creates a sense of belonging. We need to have community integration. You feel less alone because people, will have you in the community and count you as one of them. So we need to involve people living with cancer or through cancer in all that we are doing, whether it's in the support group, online or in person, in the awareness campaign. I say meaningful. When you engage people with lived experience meaningfully, it has a very big impact. There is hair falls because of cancer. That is what we are told. It will mean very different when I stand and say my hair fell. This is my picture when I was bald. I was bald, so my hair fell. So it's very important to have meaningful experiences in the public campaign awareness. And then we have advocacy and storytelling for impact. I think it's very different when somebody comes and starts advocating for something that they feel is a need, as opposed to things that people feel they want. I usually say, if I have a platform, I'll talk about, personally, I went through breast cancer, the need to have prosthesis and mastectomy bras, and probably have sleeves. And somebody else may be in the same space who has not gone through cancer, will advocate for something else. We say we need hair wigs. It is okay, but if you ask a person with a lived experience what they really need, will create a better space as opposed to what people think we want. Then we have storytelling for impact. When you stand up and give your stories, you're not just giving a story, no, for sure, or people think, no, it has an impact. So people in the community will say, hey, amongst ourselves, there are people who have gone through cancer, seek treatment, and they're standing. So if this happens to us, it is good that we also take the initiative that they took, go seek treatment, and get treated. Then we have volunteer opportunities. Yes, volunteer opportunities. They are there, but this is a plea that I usually see. As we are saying volunteer, we also need to be looked at. I can't volunteer in the morning, lunchtime, at noon, tomorrow, and another day, another day. Yes, I'm a survivor. I'm empowering people with education, I'm giving hope, and I'm creating the ripple impact to the community. But hey, I need to go for my clinics. And when I go for my clinics, I have to pay for consultation. There is follow-up. If there's a scan to be done, I have to pay. So it is time we look at monitoring that. We lose volunteering, well and good. And some places we can't volunteer. We need to pay school fees, we need to pay house rent for our people. So that can be looked upon, but where we volunteer, we give it our all. Then we have the physical rehabilitation. So how do you rehabilitate? What I think is, I want to say that just, some of the organizations that we are here are doing a good job. I know people who are knitting knockers to help women rehabilitate and have their self-esteem. I know people who are building, who are knitting beanie, the hats, yeah, so that they can help rehabilitate our people who have been impacted and going through cancer. So I would like to mention 1 or 2, 3 things. People that have empowered survivors in the community to be productive. Amani Counseling and Training Center. I really want to acknowledge the work that Peter Nyenze is doing in using wounded healers. Cancer survivors are being trained to become counselors. It's becoming very, very helpful. It's sponsored, it's free, and you get a certificate to practice. So I want to say thank you for empowering cancer survivors. We have the Afresh Chapter team that personally I am in it. We say that we go to the ground to talk to our people about emotional healing. And this we do to the grassroots, to the underground. That is what we usually say. And we have online, and we also have the in-person workshops, and they facilitate the survivors that are there. And of course, it is paid. Then we have the Faraja. Faraja is doing a very good job in offering different sessions and services to the survivors. Yes, we have the knitting, we have the yoga, we have the art, we have the lymphatic drainage. This empowers all the patients and survivors in the sphere. So Faraji is also doing a very good job in terms of empowering patients and survivors. Then there's Hope on Fit is an organization that is found in Dandora. It has worked with Strathmore University and Women in Business, and it's giving training to women about business in 6 weeks, and is satisfied. It is certified. So those of us who wish to do business or are in business, we are gaining and you're being helped by Strathmore University, WISI, and Hope on Fit. I think we have also KENCO training and working closely with the survivors. It is the umbrella body that has almost 78 organizations. And in many fields, I believe they had recently a workshop on cervical cancer. I know they are doing something about cancer in science, navigation, and all those things. We acknowledge that is empowering survivors and making them live a meaningful life and engaging them fully. Then we have Warriors of Hope in Mombasa. They're doing a very good job. They're navigating and linking and also offering psychosocial support. I think Sydney had mentioned about Kilele Health, doing the mountaineering and doing storytelling for impact. We really acknowledge that they're doing a good job in empowering survivors to speak about their stories when and how and at who, and getting the ripple impact. I also want to acknowledge the NCCP. Most of us, personally, I sit in various technical working groups, and thanks very much for the meaningful engagement. Yes, we need to have our inputs in matters of cancer. We are the ones who are afflicted. We are the ones who knows where the pain is at most. And I really want to also acknowledge Kenya Stomy Association doing very well in providing stomach bags to the patients who have colon cancer, and they need stomach bags for rehabilitation, and it's done for free. Together with the Stoma World, thank you very much. I want to acknowledge Symbol of Hope in Kariobangi. They are offering accommodation to patients who have come all the way from upcountry to Nairobi to seek treatment in Kenyatta or KU for free. They offer accommodation, they offer food and everything, and also navigation. This is what I say, it's called meaningful engagement. I know we are all at different stages and moments and levels in survivorship. I want to acknowledge those people who can speak out boldly and stand and talk about it, and those people who are still healing and also requesting to have time. We also have Better Life in Bungoma. They are doing avocado and beekeeping and also tailoring. I really acknowledge people and survivors who want to be empowered, because I said stigma is both self and external. So you refuse to be self and you don't practice it and say, hey, I can do something. All these people are doing something that are aligning with patients, fellow survivors, and creating impact in our society. Maybe something I would want to say about survivors, there are some 2 or 3 things that we can stop doing. We can stop taking things that are not meant for us. Most of us are good in advocacy, most of us are good in storytelling, but when it comes to matter medicine, please allow the medical practitioners to do their work. They've gone to school, they know what is best and not what is best. Because of this, we have had something that I call hyena called suffering, which is a conflict between the family and the patient who is going through treatment, and also anybody who is navigating them. They tend to feel that they know much, and they inflict suffering to the patient. And with this, we lack empathy and care to our patients. So kindly, let us not go and try and offer solutions where we cannot offer. I had mentioned also about, I believe in God, matters faith. That's something that we survivors, we call it toxic positivity. It's good that when you have a cancer diagnosis, you go to the hospital and get seen, because the only place you got your diagnosis in the hospital is not in the church pulpit, it's not from your bishop or the prayer warriors or everything else. People, let's give people the right information. Let them go to the hospital, get treated, adhere to treatment and follow up. And then we can choose our words that we use carefully. It is very important. the words that we are using to fellow survivors, to fellow patients, to everybody else in the community impacted by cancer. We should be careful. Tunaenda hivyo tunakwaruzana wengine, tunapotosha wengine, na si vizuri. Then I have a rhetorical question, something that has been bothering me. As Lucy, somebody that lived experience as a breast cancer survivor and have gone through everything. Is cancer a death sentence? I don't want you to answer me. When somebody tells me that my mom died because of cancer, I've lost my patient through cancer, and you're here telling us cancer is not a death sentence, what do you mean? I've gone to places, we've gone to places, and people are asking us why we are not dying, and their people have died. It's something that is really tormenting me. I don't know what to say about it, but we could rephrase and say, cancer is treatable. There's life after cancer, and treatment has two ways. Personally, I lost my mom to throat cancer, and here I am 9 years later when I got my breast cancer diagnosis, healthy. I have never questioned where she got treatment and why she died, because eventually all of us are on transit. Thank you.
Wow, thank you, Lucy. Again, McCarthy with the emojis. Thank you, Lucy, for sharing your perspective, your story, your recommendations. Truly, truly insightful. I like what you said, that it's important that we invite the people with the lived experience, you know, to offer solutions, you know, asking them, what do you need, instead of, you know, people from the outside wondering what they need. That way we're able to be more effective, because it's actually something they need. Thank you so much, and for plugging us with all the amazing survivorship networks that already exist locally. It's good to see that despite the fact that the survivorship network is not as strong locally compared to globally, we are not at zero. And that's a win. So we keep building on from there. Thank you so much, and we celebrate you, and we celebrate you using your voice to empower people. So now we'll go to the Q&A session. I can see several questions and comments. Thank you so much. So I think I'll just read them, and I will be directing them to the relevant speaker, yeah? So there is, how does coffee and tea predispose one to cancer? I think that's yours, Eric.
Yes.
Thank you.
Oh, sorry.
Yes,
can
you
wait.
can note that one. I think you can answer all of them once they're done. There are not so many. Actually, there are very few. So that's the first one. How does coffee and tea predispose one to cancer?
All right. Sure.
The other one is, thank you for this information. Looks like this cancer is a monster that has issues that seem not to be addressed. Can we have several research to unearth the real issue? I think I would borrow from the perspective that Lucy has shared, that, you know, this is not a death sentence. And I do agree with you, Josephine, that research needs to be done. And I think it actually, not I think, I know that research is still ongoing. There's another one. Does Yakon help in treatment of cancer? I think that's also yours, Eric. Yakon is Y-A-K-O-N. I don't know what that is. I hope you do. Does
Okay,
Yakon help?
respond.
Okay. There's requests for the presentations. Okay. Then there is, are there herbal products that can cure cancer? I believe that's also yours, Eric. So for all the
Yes.
for all the people asking about presentations,
Okay.
we'll liaise with the team to provide. Yes, and then yes, the other one is a comment. Someone commenting that nutrition, a very good presentation, and emphasizing that we could consider kitchen gardening. Yeah, small ukulima. You know, that so that you get to eat safe food. And yes, thank you to Sydney and Lucy for being open and dynamic and sharing. Yes, and also supporting, you know, that there should be remuneration, or, you know, even employment as suggested, because this is work that is being done and we see the impact of it towards the whole cancer care continuum. Higher.
Now to you, Eric.
So thank you, Daktari, for reading out the questions. Now, on the link between coffee and tea, you find that we start from three perspectives. One, through the food chain processing. You notice that in coffee, there are three link or the lead chemical constituents therein that are actually have potential in triggering carcinogenesis. Namely, now one is acrylamide, carcinogen, and then the other one is polycyclic aromatic hydrocarbons, PAH, and this one formed during the roasting process. And then we also have furans, F-U-R-A-N-S. So still again, also these are chemical substances that are formed during the roasting process. Now the link can be is based on the dose response mechanism when looking at it from the epidemiological perspective. So in this case means depending on how much you use in a cup and how many cups you take in a day, then it means there'll be the risk of super exposure, which again now heightens chance. But again, also in matters studying causation, you find that independently also you cannot say directly that yes, it is now the coffee that was linking to this, but rather there are varied potentiators to this effect. Number one, for instance, you could be consuming coffee in doses, rather mega doses as outlined. But again, also remember you have a family history also of the same disease, for example, in the family. So it means now that the risk portfolio comes to 2. Thirdly, now also you're super exposed to radiations. Number 3, rather 4, you find that maybe say like there is the link of the chemicals now in the food. Now, for instance, we talk about aflatoxin, for example, which now has a direct express link to say the liver for this case. So you find that the link to real-time cancer itself is diverse. But now foods identified to contain carcinogens is what independently will heighten your risk of contracting, one, in isolation to the food itself, but also number 2, on top of the other diverse potentiators to onset of cancer. So think of radiations, be they medical imaging procedures, or the sun, or that UV light exposure, besides now the tea and coffee concern. So there are these 3 chemicals during processing that are now that have expressed link to cancer. Now, still on the polycyclic aromatic hydrocarbons, that's the same thing common in meats. Ile nyama choma, ile aroma alafu inakuwa crispy or rather crunchy na jivu. Hiyo jivu constitutes polycyclic aromatic hydrocarbons in itself, also linking now the issue around meats and cancers, like say of the GI. So you find that you are doing roast meat to that degree, and then number 2, you also now using super doses of coffee, given now depending on how the environment can, or the cold the environment can be, or for the interest of revising, for example, so you want to stay late at night, so then you want to remain alert. So the dose response mechanism is what potentiates risk. And then now the other domain is in terms of manipulation at service. Manipulation at service means if I want to take my tea, or coffee, I'll make it rather prepared to my taste. And remember, coffee will taste better once it has got an optimum level of sugar to inform the taste buds. So you find that as hotter as it may be, so equally it means it has to taste better if now there is enough sugar therein. That aside, you also find that now the third component of it in terms of temperature at consumption. So by the mere fact that, of course, coffee tastes better when also it's hot, or even tea itself. So the lower the temperatures, it means also, of course, the minimal the risk. But then the issue here is the scalding effect, given now the nature of hotness, is what now can actually lead to matters oropharyngeal challenges due to the scalding effect. Because it's more or less like you melt the mucus lining within the oropharyngeal pathway all through to the esophagus. And then on the other end, now, depending on the richness of the additive therein, now this talks about sugar and the accompaniments. It means now those are extra energy consumed that accounts for overweight and obesity, which in itself also independently is a risk factor to these forms of cancer. So it's not a one bullet link, but rather it's associative to other multivariate factors that can explain the relationship. Now, concerning the YACON in treating cancer, I think this is still linked to the last question on herbal. Basically, it's a herbal. I mean, YACON is used to make, some form of herbal tea. But remember, what will happen is perception is of this kind, that like in the event of, if you talk about wheatgrass, you see, for as long as a patient, say in the context of cancer, hears of anything that will actually alleviate their burden presenting, they'll jump in. Look at two scenarios. One patient whom, if you ask just to consume or drink water plainly, they may tend to resist. Even if it may be a healthy, nutritious shake, they'll tell you the taste is not welcoming. But make a concoction of wheatgrass, including also carrot therein, and based on hearsay, this patient will guzzle even 2 liters at a sitting. So, in as much as yes, there are some attached benefits around the phytochemicals therein, but the express presenting benefit that is coming out of the 2 liters is hydration. Hydration, which of course will now address the issues around toxicity, be it in the liver or generally overall body hydration. So you find that yes, they'll have hydrated, but not because YACON was the express link now in the treatment, but rather it was a vehicle of seeing this patient X or Y consume now adequate plenty of fluid. Now, maybe a case example would be like during the times of COVID. You find that people were poor, generally are poor hydrators of plain water, but in the event now COVID came in, therefore vitamin C was the chase, you would see people walk around with the water bottles and they would clear and also refill the soonest. So independently, yes, they hydrated adequately, but remember now you wouldn't say that now lemon at that time. Of course, as a vehicle, it helped in improving the palatability of the water, but then now it wasn't now the cure in target. So of course, there'll be phytochemicals. Now, of course, the benefit will be of significance if also you take in larger volume. So the link is it helps in hydrating, but not necessarily as part of treatment in the context of cancer. So is also tied to the question of products. Remember, besides now the issue of drug herb interactions, which means now it also becomes where a patient is doing combined therapy. Because you see now minimal research has been conducted now to establish on the safety profiles of some of these. So you find that yes, while you're on conventional treatment, and then now you also flash in now the herbs, then you find that interactions with mainstream treatment, drug herb interactions are a reported concern, which of course now you may end up seeing a person now presenting with complications, and they can hardly report. They can hardly report to say, by the way, other than what I'm getting from this facility, I'm also, consuming something on the side. So that's why the advice would be treatment post-diagnosis should be definitive in terms of you choose as a patient that you want to pursue mainstream conventional treatment, so that now even M&E monitoring regulation can be defined, rather than now if there is back end concomitants of that kind in terms of now the herbs, of which now the safety and also certainty in terms of therapeutic doses and benefits are not defined. But also, you find that industry is also scavenging on patients, if I may use the word, to mean the anxiety presenting post-diagnosis will also want to see people walking whatever kind of that has been discussed online. And you see, online evidence to justify the recommendations. So choose one direction, with the combination. But mainstream is choose one pathway that is defined. But remember, exploitation becomes the new risk in matters cancer management and treatment. But remember, over also hydration, because the main given gas and constipation at the expense of now feeding on, like, say, porridge, sugar-free. Badly, if I'm going to use the word. So ideally, the issue of concern here is treatment, even during in this over to you.
Thank you, Eric. As I said, nutrition is it's a catchy topic, and actually there are more questions for you. So there is can someone comment on the consumption of supplements in cancer management? And then Victor mentions that he once heard that there's an association of MURSIC with esophageal cancer. How is that associated? And also, how has tea been associated with increased risk of esophageal cancer? Although I think you might have mentioned it. Oh, there's also a request. I think this is for Lucy. Kindly share the various cancer support groups again. And I think this one can be both Lucy and Sydney. What about the care to family members of the cancer patients and survivors? Sydney,
Okay.
are you able? Or rather, maybe Eric, you can finish the nutrition ones.
Yeah, sure. So on the issue of supplements in cancer management, you notice that you cannot, you see, when you talk about supplements, I suppose is what is mainstream in the common markets, pharmacies or related, everybody selling around in the name of the existing food doesn't have nutrients. That cannot be the solution to the challenge, but rather it requires is a defined diagnosis that will inform or the shape the intervention to be rendered. Now, in the context of, say, nutrition intervention, in this case, you find that now we use what you're calling nutraceuticals, or the products that are designed to respond to patients presenting with unique challenges. Not now like, say, multivites or powders, be they, say, wheatgrass or related. You know them, they are all over in the market. So that's not the direction, but rather, one, in the nutrition first environment, you find that number one, if, say, for instance, you had a condition like, say, gastritis or a gastroenteritis, then you are given a product or a prescription that is gut friendly to allow for addressing issues around hyperacidity. So now you rehabilitate the gut, so it means you're feeding the patient at the same time also rehabilitating the gut to be able to allow for restored absorption the usual way. But even if you are to take handfuls of pills in the name of supplements in the management of cancer on an empty stomach, success is limited. So basically, the word here is get advice from the professional. They do an assessment and then intervene, not now with in the form of pills or maybe powders, but rather if you're able to eat orally, then now they design on matters food combinations to suit the pre-existing condition. Because you find that, say, if you're undergoing, radiotherapy, for example, that now has caused issues like, say, enteritis, then it means the inflammation within the colon has to be arrested via dietary modification to be able now to accommodate, restore, or rather rehabilitate normal gastric function. So not in isolation, but rather you need a prescription defined to suit the existing challenge hands-on. Now, MURSIC and cancer of the esophagus, I suppose that one I would say it's a limited conclusion based on now, like the evidence is limited, because you find that don't look at now the MURSIC user in isolation, because there could be a MURSIC user. Of course, there is the issue of the tartness, so more or less the acid therein in the milk. There also, now, say, let me give you this example. Already you have a scalded oral cavity towards the esophagus independently. You have recurrent URTIs. And then number two, you have conditions also including, say, reflux, which means now there is the throwing up of acid, now even further causing further corrosion in the esophageal cavity. Number four, possibly a smoker. Number five, then co-infections also are setting in about the same. So you find that the causes are myriad, but not in isolation to MURSIC alone. And that's why, still linking to the question of the need for more research in the subject of nutrition and cancer, you find that to prove causation in human subjects is a very limited field in terms of the ethical interest, because there is no way you can say, I want to have 5 adults now from whose home, whom you want to isolate from certain foods in the name of you want to do, I mean, you're using human subjects to conduct research to give evidence. Ethically, it becomes a challenge to get approval from relevant bodies in that direction. So ideally, you find that, so from the epidemiological results that are actually available, it's actually you work with the proxy causation linkages rather now definitive, that we gave 10 people this kind of food, now they also now have cancer. Now that actually may not augur well in the research space. Now, and green tea in relation to cancer still is in the area of herbal teas, because remember I mentioned, don't look at tea at the table, look at tea right at farm level, and then tea, because you see there is also the control of weeds in the farms, and then in the chemical fermentation processes involved. And then now, before now the roasting has come in, other drying processes, and then now it's now on your table. So the dose response mechanism I mentioned, but again also the other side support risk factors, including now say smoking, alcohol consumption, overweight and obesity, and the rest of such. So even green tea itself, one would look at it in terms of one, hydration. But you see, the myth attached to green tea is in terms of treatment, but rather look at it from the perspective around hydration with some segment of phytochemicals. But remember, for the phytochemicals to be of significance, it means actually you even need, a plateful of green tea as a powder, not as a solution, because you can hardly take 4 cups of tea at a sitting. So you find that generally hydration is the major banking that can actually be the benefit expressed to this. Mercy is mentioning that a frequent daily consumption of MURSIC, especially among those who consume it as a staple, can lead to prolonged exposure to the esophageal lining to these harmful substances. So still tied on to the other core risk factors that are mentioned, that now can see this become a real association in terms of causation of CA esophagus. So it's not expressed, but there are other core support entities. Yes. Anything missing?
Thank you. I think you have been able to answer all the ones that were directed to you. Sydney, maybe if you could help us with what about the care of family members of the cancer patients or survivors? Do you like to input something?
I'd like to say that cancer is a disease that affects the whole family, from the siblings to the parents to the other relatives who will support, to the community at large. And one of the things you realize is, especially when one gets cancer and is going through some of these procedures, you find that the caregivers are very much affected. In fact, a lot of the time, especially when it comes to childhood cancer, the parent has to actually stop working to be able to take care of their child. Or you will find a daughter or a nephew or a niece will have to step in to give someone round the clock care or to make sure that they navigate them through the hospital. And you find a lot of the time there's a lot of burnout, and not just for the caregivers who are related to the survivor or the cancer patient, but also the medical team can have medical burnout. So there is also a very large need to support the caregivers of the people who are taking care of people with cancer, and also the medical team, because a lot of the time, for example, in childhood cancer, where we have a survival rate right now of about 20%, which means 8 out of 10 children will die. As much as we are trying to increase that, you find the nurses and the doctors and then the rest of the medical team in the hospital has a lot of stress. And a lot of the time, when you keep losing people and you keep losing people, no matter how best you try, it becomes somehow taxing on the individual. And unless they're able to deal with these mental issues, from the caregivers to the medical fraternity team and the rest of the community, even just giving people some information on small things like someone saying, "Don't play with my child because don't play with that child because they have cancer." Educating the community that cancer, number one, is not communicable, and secondly, that is just a disease like any other disease, and these people really need support. So I would just urge people in the community out there, one, take care of yourself. If you're a medical professional, seek that counseling, take that time to revitalize, and secondly, if you're a caregiver, also you need to take time to take care of yourself, because if you are not in the right state of mind, or if you are extremely stressed or burdened, you won't be able to give the person the support that they need. Thank you.
Thank you, Sydney. I think we have answered almost all questions. Yes? We
You had
need to.
talked about the support groups.
Huh?
I usually tell people,
Yes,
within-
Lucy.
yes, that is one of the best safe space that patients and survivors have, because they are themselves, they bring about conversations about themselves, they share their story and their experiences. There are many support groups spread out in the country. So I usually ask patients or people that have a cancer diagnosis to join one that is in your community. We also have online ones, but I also tell people join one that suits you best. Probably if I joined one that I don't resonate with, or with my diagnosis, I would feel off. So if there is one that I know for prostate is just for men, they don't allow women, whether caregiver or wife to the patient, and it is well because that is their safe space. That is where they can do their sharing and become vulnerable. So Matter support group, they're everywhere. Be in touch with one. We also have support groups even in hospital settings. So once you have a diagnosis, you can ask if that hospital has a support group that you can join. And the one ask that I would have of today's meeting, at the point of diagnosis, can we have, when the doctor is breaking the news that I have breast cancer, you have prostate, can we be having a nutritionist seated right there? Can we be having a counselor seated right there? Can we be having a navigator seated right there? Those people are very, very vital and very important, because where we are losing it, because we don't have people to hold on. People don't know where to face, where to ask, or whom to fall back to. So if I have a diagnosis and there's a lot of in the information outside here, whether in the social media, whether fake or real, about nutrition, if the nutritionist is there, they'll be able to guide me very well. If the counselor will be there, I'll be able to go and open my heart, outpour myself. So mambo na anxiety and depression will be less talked of, because we're having people who are overcoming cancer only to commit suicide. And you look at all the effort that was put, and now this person is standing, they've lost them to the to depression. And also, let us start looking at the NCDs that are coming up. Yes, we are beating cancer. We've put a lot of effort, but we now need to look at things holistically because there is something that needs to be addressed. Thank you.
Thank you, Lucy. And I do agree with you. Yeah, there's need for that navigation there. And also, in regards to the support groups, I think maybe we can have a central place where maybe they're listed or someone can be able to find, because I do resonate with the person who asked that question, where sometimes they're not very visible. They're probably visible to the one who's, aware. It's like one of those, if you know, you know. If you don't know, you don't know. But I think that's a challenge to,
We have
the
Kenya Network of Cancer Association. We have KENCO.
Okay.
KENCO is the umbrella body. And most of the organizations that are registered in KENCO, you can get access to. And they'll even tell you the specific place that they are found. If they're in Kisumu, they'll tell you. If they're in Webuye, they'll tell you. If they're in Kisii, they'll tell you. So it's good that you liaise with KENCO to help those people who need to know more about support groups and their locations. Thank you.
Awesome. Thank you. So we start at KENCO. Okay. I think this, allow me to take this one as the last questions, because you see we are way past time. And I think, yes, these are probably yours, Eric. So there is, there's a myth regarding milk. Can milk cause cancer cells? Increase cancer cells? Is it good for a cancer patient to drink milk moderately? I've also had this several times. And then how should news of diagnosis of cancer be done to patients? And how can you take care of relatives who resist that patients should not be informed of the diagnosis? Sydney, Lucy, you can take that one. But for now, Eric, Maziwa.
Okay. This from Buloba. One, I would say the answer is no for the first question. That can milk increase cancer cells? I would say no. But on the second part, there is the issue around the gut health of the person undergoing, say, treatment for cancer. Remember, for instance, and you'll see this in most, say, patient, say, spaces, be it at home or in the hospital, other than food, instead of food, the cheaper access item would be either the soft drinks, that is, say, Ribena, in the name of, say, boosting iron. Number two, of course, Lucozade. And then number three, of course, now, yes, milk comes on board. More or less because there's more or less leaf fluid. So the patient doesn't have to struggle a lot in terms of swallowing. But remember, independently, even before you are a patient, if you just take plain milk in itself, you find that it tends to stick on your tongue, right? So all along, for like say a person who is, for example, already having thrush because they've taken longer hours or days minus feeding, then it means even their GI is compromised, meaning the absorptive surfaces have been interfered with. Now you pour in milk. Remember also milk in itself also is preserved. Now in particular for spaces around preserved zile packet alternatives, there are elements like say hydrogen peroxide used in preserving. Recently, there were stories around formalin also being part and parcel of the discussion. So you find that now, with already compromised lining of the GI, then it means co-infections set in. So, like for example, thinking of matters, peptic ulcer disease setting in, or even gastroenteritis now with time, you find that not that now the milk is what has been the issue directly to the cancer itself, but rather now it actually now supports the proliferation of the gut, the unfriendly gut bacteria, like in this case H. pylori, to thrive. Remember also, even to digest the milk, also there are patients who've got the notion that milk is the solution for ulcers. That is wrong. Because you find that independently, as you pour in the milk, number one, of course, it will tend to dilute part of the existing pH at the moment. But to digest the protein and the fat therein in the milk, the body has to generate more hydrochloric acid, digestive acids, to come and now work on the milk for that purpose. So eventually what happens is the threshold of the gastric acid level goes high in terms of volume, but the pH, of course, now shall be lower. It significantly get lowered. That contributes to inflammation. Now, it is this inflammation, and of course, you cannot make long call out of milk, that explains matters around bloating, gas, and therefore constipation. Now, with the progressive colitis, then you find that now there is also diarrhea setting in, because now you are not actually in any way absorbing any of the nutrients that get into the stomach. So, including the fizzy drinks, now the carbonated drinks, now it becomes a crisis. So, for as long as the gut has challenges, ideally, it should be an omission. So that now you consume that which is mild, like say even just plain porridge and sugared, to help in starving the bad bacteria while cushioning the GI lining against attack from hydrochloric acid. Otherwise, it becomes complicated now once somebody is complaining about abdominal pains. Now, in this case, in the context of peptic ulcer or gastric ulcer disease or abdominal ulcers, and then top it up now using now wrong interventions in the name of feeding, like this example being now the drinks mentioned and even now milk, that now tends to worsen the condition. So ideally, where there are existing challenges in the GI, that's why I said a nutritionist has to be on the forefront. So that, like my colleague has mentioned rightly, that at diagnosis, let there be near a panel so that everybody will pick their pockets to fill in. So that if patients raising concerns, he or she sees solutions across the table, across the panel, that I know there is James, there is Peter, there is Charles, or Gladys, or Jane, whom I'll reach out to in this hospital whenever I'll have challenges. So that's why now, like in my discussion, my focusing was on outcomes. Outcomes can only be accelerated if status quo is reversed. Thank you.
Just to finalize and add on to what my colleague had said, I think in terms of delivering the news of the diagnosis, number one, I know a lot of the time our healthcare professionals are strained, or they have so many patients that they see in a day. And also the burden does not fall on the oncologist by themselves or the doctor who has diagnosed you. We should move to an approach that mimics what was done in the 1990s with HIV and AIDS. And as Lucy said, at the point of diagnosis, there should be a counselor right there. Because some people think cancer is a death sentence, others think it is a curse, others think they are going to face stigmatization from their family or community members. So you need to sit down with this person and have that have that compassion and empathy, and listen to what they are saying. Because at the end of the day, if they are resisting to give that to let the patient know, especially in the cases of children, this child is not stupid. This child will be in a ward with other children. They will talk. They will start hearing the word cancer. If you're not telling them anything, they will ask somebody else. They will learn they have cancer. They will start wondering, why am I not being told it's cancer? Why are my parents lying to me? And we have had cases like this in the past. But at the same time, the child needs to be aware of what their body is going to go through, whether you're a child or an adult. But also sit down with these people who are resisting and find out what are the core reasons. Is it a cultural thing? Is it a myth they have been told that you can easily demystify? Is it there could be so many different reasons why someone would resist letting the patient know that they have cancer, or even that some people just say, I don't want treatment, I'm going to be treated by my pastor, I'm going to be paid for by my pastor, and that's the end of the story. And there's nothing wrong with having faith, but at the end of the day, you need to tell this person that as much as, yes, you have your faith and you need to be prayed for, you also need to acknowledge the fact that it is God who has given these doctors these skills and abilities. So it is a long process of trying to demystify the reasoning behind that resistance, because at the end of the day, even if it is a child, they need to know what is going on with them. And even though they cannot be involved fully in the decision-making process, they need to be aware of what is happening. So have a counselor at the point of diagnosis, have the counselor sit with them after the doctor has finished with the diagnosis for just a few minutes, 5 minutes, just to enable them to understand what is going on. And if that is not possible, look for an organization. Ask the doctor or the oncologist if there's an organization that caters to that specific kind of cancer that the patient or the child has. Thank you for that.
Okay, thank you. Thank you. Thank you, Sydney. Thank you for answering that. Thank you, Lucy. Thank you, Eric. Thank you for all the insights you've been able to share with us. Yes, the session will be uploaded on the YouTube channel. So in case you missed anything, in case there's anything else you want to just listen in again, that will be there, and the presentations will be uploaded on the KenH Research YouTube channel. Just a few reminders before we finish. Visit the nccp.or.ke for more information on the Ministry of Health's policy document. NCCP is National Cancer Control Program, right? They are one of the co-hosts, for this webinar. Also visit Ministry of Health Virtual Academy. There you'll get CPD accredited short courses on early diagnosis of cancer for primary healthcare, among other courses. There are actually about 109 courses available there, and they're all free. And just note that wherever you are, there is something you can do to improve cancer survivorship through either early detection and screening programs, diagnosis, treatment, and post-treatment support. Thank you all for being part of this conversation. I hope it's been impactful. Another thank you to our speakers. You all are amazing. Yeah, I think it's safe to call it an evening, right? Haya, kwaherini.
Thank you. Bye-bye.
Bye.